If you don't know me, I'm Dr. Cush. Some of you I recognize. Some of you have my scars. Some of you have carpal tunnel before. Again, thanks for coming on this kind of crappy day. I had to come to work today. You didn't have to come here tonight, so thanks for coming. This is awesome. Good group. Tonight I was charged with the task of talking about something. I chose peripheral nerve compression syndromes, only because it's so very common. These are things I saw all day in the office, things that you guys might presently be experiencing. I chose some of the common ones. We could talk for hours and hours and hours about nerve problems. I chose to talk about 4 or 5 of them. Number one, and probably the most common thing I see regarding nerve compression, carpal tunnel syndrome. I'm going to shed a little bit of light on something called cubital tunnel syndrome. We'll talk a little bit about cervical radiculopathy, that's a neck problem, as well as lumbar radiculopathy, low back problems. Radiculopathy simply means nerve root impingement. Nerve root isn't functioning well. Causes, what causes carpal tunnel syndrome? Number one, I think probably repetitive motion of the hand, wrist, and fingers. If you're a factory guy doing the repetitive thing over and over, you work at Sano, these are the kind of things that can cause compression of the median nerve, that's the carpal tunnel nerve, here at the level of the carpal tunnel. Age, a close second. As we get older, the space available for that nerve going through your wrist and hand becomes smaller. Inside your wrist, we call it carpal tunnel syndrome because there really is a tunnel right through here. What goes through the tunnel are 9 flexor tendons, all these bad boys that let you do this, along with one nerve called the median nerve, that's your carpal tunnel nerve. As we get older, the roof of the tunnel, it's a ligament. It's called the transverse carpal ligament. It gets thicker. The word we use is it hypertrophies. If it gets thicker, well then it's going to start to squish down and make that space available for the median nerve quite tight, quite small. Pressure on nerves makes nerves die. Nerves don't like pressure. Trauma. Falling down, landing on your wrist, fracturing your wrist. Every time I have to fix a wrist fracture, plate and screws, I always do a carpal tunnel release while I'm in there because that median nerve is injured. When I'm opening up the wrist and I'm looking, I got all the tendons in the way, get down to the bone, that median nerve oftentimes is just purple and bruised, seldom lacerated, just injured. So trauma can cause it as well. Symptoms: pain, numbness, tingling, loss of dexterity, easy fatigability. Pain, just achiness, usually night pain is what I get a lot of times. Folks have to kind of shake their hand over the side of the bed and they're forever just doing this stuff. Driving down the road, having to switch hands on the wheel, they find them doing that. Talking on your cell phone. Well, hold on, baby, I'm sorry. What'd you say? Yeah, my hand, Jesus, it's killing me. That's the kind of pain. Loss of finger dexterity, referring to the fact that I'm having trouble picking up those coins anymore. Or somebody who really likes to sew or crochet, it's becoming more difficult. They just can't do what they always used to be able to do. Easy fatigability simply means the hand feels tired out. Those of us who still write checks, everything from in my house via my wife is online banking, but just sitting down and writing checks or doing something over and over and over, folks will start to describe pain, numbness, tingling. Physical examination, how do we diagnose it? Positive Phelan's test. Phelan's test is just this. Ask the patient, and I do it sometimes I don't. I don't think Phelan's is the best test. Kind of wrists come together like this. What that's doing is compressing the carpal tunnel. You have patients sit like this for 30 seconds to 60 seconds. When they're done doing that, oftentimes they'll say pain, numbness, tingling, that kind of thing. Diminished sensation, I just described it. The distribution of the median nerve is thumb, index finger, long, and this half the ring. It's pretty cool how God made us. That is very, very constant in humans. Treatment for it, sometimes bracing, especially at nighttime. Nighttime splinting or bracing seems to help a little bit and maybe for a short period of time, mostly because I think when you're braced, it kind of keeps that wrist in a neutral position. NSAIDs, non-steroidal anti-inflammatories, sometimes your ibuprofen, your Aleve, a newer one out nowadays called Mobic. Sometimes non-steroidal anti-inflammatories can help diminish inflammation within the carpal tunnel. Therefore, the space isn't quite so tight. Sometimes that helps. Endoscopic, that's how I do it, kind of a newer way to do it. I do the same operation, I just do it under the skin. Instead of a big formal incision on the palm of your hand, which again is fine, that's how many guys do it. I make a little transverse incision just right here across the wrist, and I do the same operation, cut that transverse carpal ligament under the skin. Again, all we're doing is opening up the tunnel, cut the roof, so hopefully now, since there's no more pressure on the nerve, that nerve recovers. Now we're talking about the elbow. Cubitus in Latin means elbow. Carpal, I should say, carpal means wrist in Latin. Cubital is your elbow. Why do you get cubital tunnel syndrome? Usually from repetitive elbow motion. Again, whatever your job dictates, you're always pushing, pulling on a lever, doing something like that. Probably age is equal to repetitive motion or at the elbow. As we get older, there's some tissue here right over this medial aspect of your elbow. It's called the fascia. We have fascia all over our bodies. Whenever you have a hernia in your abdomen, people say, oh, I got this big bulge here, a hernia. That just simply means there's a defect in your abdominal fascia that allows a little loop of bowel to kind of knuckle through. That's what a hernia is, a defect in the fascia. Here, it's not that there's a defect in the fascia, a hole in it, but rather as we get older, that stuff can get quite thickened and hypertrophied and then put pressure on the ulnar nerve here at the elbow. Now, I got plenty of patients who come in, they've got cubital and carpal, where every finger feels numb. But again, cubital tunnel syndrome, ulnar nerve problems, again, small finger, this half of the ring. Kind of cool how God just made it that way. Diagnosis, like everything else, it's physical exam. We do have, of course, at our disposal, nerve studies, EMGs. Likewise, nerve studies will show clearly whether, in fact, you have damage to that nerve at the level of the elbow that's giving you the symptoms down into your forearm, small and ring fingers. Nerve studies. Treatment, very similar to carpal tunnel. Vitamin B12, sometimes NSAIDs. It's really hard to brace the elbow. There really is no great bracing option for the elbow with cubital tunnel syndrome. Therefore, if you've got symptoms and your nerve studies confirm cubital tunnel syndrome, and if you say, this affects my lifestyle, I'm not living like this, okay, next step, surgical. What you have to do here is make an incision right here at the elbow to once again just decompress that nerve, make sure none of that fascial tissue is squishing and pressing on it. Cervical radiculopathy. Cervical means neck or head. Radiculopathy, as I point out, that means injury to a nerve, okay? Reasons for that. Number one, age. Everybody's got neck pain. I have neck pain. Haven't done x-rays or an MRI yet, but I bet I got something going on. Age meaning you just wear out. You get arthritic changes in your cervical spine. You form osteophytes, i.e. bone spurs, which can start to put pressure and compress on the nerves where they exit your spinal cord. Trauma, sure, get in a bad car wreck. You damage you break your neck. You injure those nerve roots just from traction. You get thrown out of a car and you land on your neck. You can injure the nerves that way, giving you then pain, numbness, or tingling that radiates all the way down. It can go down to the fingers. Depending on what nerve root is impinged upon in your neck, that determines where the numbness is. The most common level to have disc problems in our necks between C5 and C6. There are 7 cervical bones in your neck, usually between the 5th and 6th. That's where most people get degenerative disc disease or herniated discs. That's the most common level. If you pick off that nerve at C5, C6, that's going to be numbness, tingling, kind of down through here. If it's more 6, 7, you're going to have more numbness. It's kind of on this side of the arm. See, the nerves are very specific as to where they give you sensation. Loss of dexterity or weakness. Again, if you have enough injury to nerve up here, you're going to lose strength in that hand. You're going to lose your dexterity, just like you do with carpal tunnel. And that's why, again, it's so important to get your nerve studies after your physical exam. So nerve conduction studies, or what we call EMGs. And a very nice test to do, of course, is an MRI of the cervical spine, MRI of your neck. That will give me all kind of detail. It'll tell me, man, is that osteophyte? Is that a bone spur pushing on that nerve root? Or, oh my gosh, look at that big old juicy herniated disc. C5, C6, putting pressure on the nerve root. Treatment for cervical radiculopathy. Anti-inflammatories, non-steroidal anti-inflammatories. Again, back to the Aleve, ibuprofens, Mobix, all those things which you've had for a long time. Sometimes wearing a soft collar can help the symptoms, but nobody wears one out. That's something they might throw on at the house. So collar use, most people don't want to tolerate that. They don't want to do it. Physical therapy, that's the first line of treatment. Cervical spine stabilization exercises and or traction. Whether it's a herniated disc in your neck or, and we'll get to it here in the very near future, herniated disc in your lumbar spine. Studies show 85% of herniated discs get better without surgery. They just get better. Over time, that nerve roots becomes less irritated, therefore your symptoms just improve spontaneously. So if somebody tells you you have a herniated disc, this is an aside, don't go rushing in and let some spine guy open up your back or your neck. Unless, of course, you've failed every other treatment. Because a lot of herniated discs get better. Next, steroid injections. That's where Dr. McNichols comes in here, our excellent and young, trained pain management physician. Injections in and around the cervical spine, around your arthritic joints, or they can even do something called epidural steroid injections where they inject cortisone actually into the space, the epidural space where the spinal cord lives and the nerve roots. If you can get corticosteroid, which is the best anti-inflammatory we doctors have, cortisone, if you can get that cortisone around that inflamed nerve root, that can help the symptoms. Get rid of the inflammatory changes within those nerve fibers, symptoms go away. And sometimes that is all you need. Lumbar radiculopathy. Lumbar again means low back. Cervical is your neck. Same kind of thing. Pain radiating from your low back or your butt, going down into the thigh and down into the leg. Numbness, tingling, or burning. Same symptoms as cervical radiculopathy. And again, depending on what level, what nerve root's being impinged, it could be pain, numbness, burning here in your thigh, or it can just be posterior, coming down your leg. You can have just numbness on the top of your foot, depending on which nerve root is being impinged upon. Diminished lumbar range of motion, meaning, oh God, I can't no longer. Forget about touching those toes. I am done. Back, each way, especially extension of the spine, really bothers people, and that can exacerbate the symptoms down into the leg or foot. Positive straight leg rate test, that's this. Have the patient lying flat or have them sitting on the side of the exam table and just prick up their leg and straighten it out. Man, they'll get fired up if they really have radiculopathy. It's pain, burning, numbness down the back of the thigh. It can radiate down to the foot. Diminished reflexes, again. Reflexes, how do they work? By nerves. If your nerves aren't functioning well and you try and do a knee jerk or an Achilles reflex, they'll be diminished or even absent. Diminished sensation, again, numbness down to the leg or foot. Corset. You see some people just wear a tight-fitting corset. They make these corsets just to kind of give you some support in that lumbar spine. Some people really think that helps them. Physical therapy, just like your cervical spine, lumbosacral spine stabilization exercises and or traction. Weight loss. We know it's a symphony between our low back musculature and our abdomen. We all do it. You can't believe that over 1 year you put on 15 pounds. You're like, where the hell did that come from? But again, if that's symphony, if this isn't balanced, if your core isn't where it needs to be, you're going to start to have back pain. If you're carrying around too much in the front, your back's going to talk to you. That's just how God made us. So weight loss can help a little bit. Steroid injections, just like in the cervical spine. Dr. McNichols, our pain guy, for me all the time, I refer people to pain management daily for epidural steroid injections or what's called facet joint injections in your back. And lastly, surgery. Again, no spine surgeon here. I've been trying for years to get a spine surgeon. I think I could keep somebody pretty daggone busy. We have a lot of low back problems in the community. But they will either do a lumbar decompression where they just do a discectomy maybe, or they'll fuse part of the spine with pedicle screws. Somebody out here might even have some pedicle screws in their back. Diabetic neuropathy. We know diabetes, having excess blood sugar for long periods of time, for years and years and years, damages the myelin sheath, the little sheath, this little tissue that covers all of our nerves. It makes nerves not work well. Ask a diabetic, do you have foot pain? It's just this burning, feels like they're walking on needles all the time. That's diabetic neuropathy. Diabetic neuropathy also is why I have to operate on feet or take feet off or do lower leg amputations, because people can't feel their feet. I can do some diabetic foot surgery without anesthesia. I can take a foot off without anesthesia sometimes. That's how numb diabetic feet can be sometimes. And because of that, they don't have sensation. They'll go home and just step on something. I've got x-rays of diabetic feet showing a nail this big in it. They don't know when they stepped on it. Isn't that wild? That's crazy, huh? So take care of your diabetes.
Thank you.
Thanks for listening. Thank you.